tonight's topic is one that so many of us, including Todd and I, have had to navigate without enough guidance, navigating life after a blood clot diagnosis. So whether you're newly diagnosed, you're recovering, or you're supporting somebody that you love, we want you to know that you are not alone. And this is one of the reasons why we selected this topic, because we knew it was so important to so many people. So a quick reminder before we begin, this session is for educational and peer support only. We are not here to give individual medical advice. Please remember to talk to your healthcare provider about any medical concerns or treatment decisions that pertain to you, as everybody is unique and your case is specific. Okay, so back by popular demand, we have Diane, who joined us here in March. We're thrilled to welcome Diane back. And for those of you who are new, just a little update on our clinical guests. Diane is an adult nurse practitioner. She is a certified anticoagulation care provider with recognized experience and expertise in managing anticoagulation therapy. She led Grady Memorial Hospital's heart failure program. She previously managed their anticoagulation clinic and cardiology department. She served at Emory Healthcare for 17 years, managing 8 anticoagulation clinics, serving over 3,000 patients. I can't even imagine what that is like. She initiated a virtual patient self-testing program as well. She's a member of the National Blood Clot Alliance Medical and Scientific Advisory Board and a former member of the National Certification Board for Anticoagulation Providers. She has her Master's of Science NP from Emory University School of Nursing. She has co-led the creation of the Stop the Clot, What Every Healthcare Provider Should Know, which is an online curriculum in collaboration with the CDC and the National Blood Clot Alliance. She has co-authored a textbook chapter in managing oral anticoagulation therapy, clinical and operational guidelines. She has published on genetic mutations related to thrombosis and strategies for reducing heart failure. She directed the development of a heart failure program at Grady that received the Gage Award in May of 2013. And she pioneered a virtual anticoagulation specialty clinic with at-home INR self-testing, improving patient autonomy and access to information. So, Diane, we are so thrilled to have you here today, and welcome back to NBCA.
Thank you so much for having me again. I enjoyed it the last time.
Awesome. Okay, so before we get started, we always have our poll questions, which Todd leads us through. So I'm going to kick it back over to you, Todd.
Thank you very much. So folks, as soon as those pop up on the screen, I'm going to read them to you. And if you could please just give a quick answer. Number 1, how long ago was your blood clot diagnosis? Less than a month, 1 to 2 months, 3 to 6 months, 6 to 12 months, or has it been over a year? Question 2, were you satisfied with how your medical team explained your condition upon diagnosis? Yes, no. Who conducted this conversation with you about your diagnosis? Was it your doctor, your nurse, a PA? No one had this conversation with me.
Mm-hmm.
Question 4, were you satisfied with how your medical team explained your anticoagulant medication with you, including any associated risks? Yes or no, or not applicable? Question 5, this is the final one. Who conducted this conversation with you about your anticoagulant? Doctor, nurse, pharmacist? Nobody had this conversation, or not applicable. And once we get those answers, I'm going to read those back to you, and then we're going to visit with our guest, who is absolutely loaded with knowledge. My goodness, what hasn't she done? We have a really good crowd tonight, so thanks everybody for being here.
Oh, I certainly understand what Katrina is saying. Okay, do we have our results?
I have not seen them pop up. Here we go.
There we go.
Okay, so let me scroll back to the top here where I belong. How long ago was your blood clot diagnosis? Less than a month, 19%. 1 to 2 months, 24%. 3 to 6 months, 22%. 6 to 12 months, 11%. And over a year ago, 23%. Were you satisfied with how your medical team explained your condition upon diagnosis? 41% said yes, but 49% said no, 9% non-applicable. Who conducted this conversation with you about your diagnosis? 74% said doctor, 10% said nurse, 4% said PA, and 7% said no one had this conversation with me. 6% not applicable. Were you satisfied with how your medical team explained your anticoagulant medication with you, including all the associated risks? 44% said yes. This is kind of disturbing. 51% said no, and 4% not applicable. And the final question, who conducted this conversation with you about your anticoagulant medication? 54% said doctor, 14% said nurse, 15% said pharmacist. Again, 14%, no one had this conversation with me, and 3% not applicable. Thank you, folks. Leslie?
Okay, so not the numbers that we want to see. We still have some work cut out for all of us, I think. Okay, so tonight, as we said, this is really navigating life after a blood clot diagnosis, and we have quite a broad group of people in terms of when they were diagnosed. So, Dane, we want to start from the beginning. You know, many of us didn't get much information after our diagnosis. So let's start with blood clot 101. What is a blood clot? Specifically, a
Okay.
venous blood clot. What's the difference between deep vein thrombosis and pulmonary embolism? And also, if you could throw in there saddle pulmonaries as well, because we've had a lot of people asking about what's the difference between pulmonary embolism, bilateral pulmonary embolism, and saddle. And then also, why does it matter if a clot is provoked or unprovoked, or does it not matter? So we'll start with what is a blood clot?
So a blood clot is a clump of blood cells and other substances that forms within a blood vessel, and it can be either in an artery or a vein, and it blocks or obstructs the blood flow and causes damage when it becomes obstructive. So some blood clots are good. When you cut yourself, you form a blood clot that turns into a scab. A scab is a form of blood clot. The problem is when it's inside a closed vessel and it obstructs the blood, the area distant to it suffers and doesn't get oxygen and nutrients and can't get the waste products. So that's why it's bad, is when it obstructs and it's not in response to bleeding, it causes havoc in your body.
Okay. And the difference between deep vein thrombosis, PE, pulmonary embolism, and the saddle PE.
Okay. So a deep vein thrombosis are typically those blood vessels that are deep inside. The most common ones we see are inside the legs, where patients will present with usually a unilateral, one-sided swelling and pain of a leg. And they're not something that you'll see on the surface. Those are superficial veins. Like if you get a clot after you've had an IV, a lot of times those will be in the superficial veins that you can see or you can palpate it. Usually the blood clot in your leg, your leg will get big and swollen, but you usually can't feel the actual clot. That's usually found on an ultrasound. In a pulmonary embolism is a blood clot that is found in your pulmonary vessels in your lungs. Typically, I would say probably 85 or 90% of them have traveled from the leg. A piece of it breaks loose, travels through the bigger vessels, the bigger veins, going back to your lungs where it stops first before it goes back to the heart. And it will lodge in the blood vessel that is the smallest it can get to. So a saddle pulmonary emboli is going to be a big clot that breaks loose in your leg and gets into your pulmonary bed, where it branches out into little vessels and it blocks all of the blood coming back to your lungs. So you can't get oxygen into your body because there's no blood getting through. The blood can't get back into the lungs to pump to the heart. And those are the ones oftentimes you'll see people that when they die from a pulmonary embolism, it's a saddle pulmonary embolism, and it can block the blood supply to the right lung, the left lung, or both lungs, just depending on where the clot travels. So those are probably the most dangerous. And those are the ones that a lot of times, if the patient lives, you'll see they're taken to interventional radiology or the cath lab, where they'll try and put a clot buster right into the clot or extract that clot with a thrombectomy.
Okay. The DVT can also occasionally come from your arm, can't it?
It can come from any deep vein. The ones that we see most commonly, I would say probably it's maybe 80-20, you'll see 80% from your legs, 20% from maybe 17% from your arms, and then you may get a portal vein thrombosis. Those I call them the weird clots, where they come from, either your splenic artery, or your splenic vein, or your portal vein. You can get clots in there as well.
Okay. And then explain to us the difference between provoked and unprovoked, and why does that
So
matter?
why it matters is because provoked clots we know why there's a reason, there's an explanation why that patient may have clotted. They had prolonged bed rest, they had surgery, they had trauma, they were on birth control or estrogens. Many common causes for people to form blood clots. Unprovoked are much more puzzling to us as clinicians, because we don't have a good explanation why that patient clotted. So we don't really know if they have a underlying thrombophilia. Even if we tested, that doesn't mean they don't have one, because we haven't discovered everything. I mean, in my career in the last 30 years, there's been several that have been uncovered in the last 30 years, and I'm sure there'll be several more uncovered in the next 30 years. So unprovoked, especially if you're a male, has the highest risk of having a recurrence. And we know that people with unprovoked clot are at a higher risk for recurrence than patients with a transient factor. So if you were in a cast and you developed a blood clot, well, you had obstructed blood flow, so you're more likely to have a clot from not having good blood return. But if you just come in off the street with a blood clot, or if you've had just a spontaneous pulmonary embolism with no explained reason, your risk is higher than a provoked clot.
That's so interesting. Two questions for you. You mentioned bed rest. How long are we talking about? Is it somebody, is it 2 days? Is it 4 days? Does it depend on the individual?
It does. It depends on the individual and the reason why they're there. Because if they're in bed in the hospital and they're septic, or they have had major surgery, or that, their risk is going to be higher than someone just laying around on the couch on vacation for 2 to 3 days. So if there's inflammatory markers that are raised because of whatever's going on in the body, we don't typically just see someone that's been laying around on the beach being sedentary develop clots. It's usually there's an underlying cause for the bed rest that is doing it, or it's because of immobility. The patient's no longer able to get up, so they're not pumping their legs, walking, and that moving your legs brings lots of blood back to your heart. Walking is one of the best exercises you can do after a blood clot. When I first started, they were still trying to keep people in bed, and we're like, no, 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 no. We want them up to move. Once they're anticoagulated, we need to get them up and get them moving, so that we keep the blood flowing.
Yeah, that's important. That's a whole different conversation, because a lot of people like myself, didn't know how long I was supposed to walk for,
Yeah.
et cetera. Come back to your comment about men who are unprovoked are at the highest risk. Do we know why?
Nope. We don't.
Interesting.
We don't know if women have a little bit more of a protective mechanism in place, or if it has to do with our hormone system, because women typically bleed every month and they don't bleed to death, which sometimes one of my colleagues once said to me, he said, I don't know, this just does not seem right that somebody can bleed for 7 days every month and still live a normal life. So I think that there's probably some protective mechanism maybe in the female body that causes us not to have abnormal unprovoked clots.
Yeah, okay. I know we'll get to this, but somebody already asked the question. So, like when I was diagnosed, I'm unprovoked, and I was terrified that I was going to have another blood clot, because the statistics say 30% within 10
I
years.
remember.
But if you stay on your anticoagulation, and we'll get to this at a different time, it dramatically reduces the recurrence.
Very much so.
Yeah. So, okay. All right, Todd. Todd, I thought you were wearing a seatbelt tonight, but I realized it's for your arm because your shoulder surgery.
One more week in this sling, and then I've had it, I'm telling you. But Diane, I want to talk a little bit about treatment, specifically anticoagulation. People are put on, they're called blood thinners most of the time. They're not told really how they work. And I think that's really important for the patient to kind of understand how they work. So I've got like 4 questions for you. I'm going to read them all together, kind of like Leslie did, and then we'll break them down one by one. But I'm going to ask you how the anticoagulants actually work. How do clinicians decide which one they're going to prescribe for you and how often it should be taken? Why it's so important to be adherent with the medication, to be consistent with taking it, and what are the risks of being on an anticoagulant or blood thinner, and can someone stay on long term? So first of all, can you tell us what an anticoagulant or a blood thinner actually is?
So it is a medication that slows your body's ability to form blood clots down, or to form blood clots. How it works is you have what we call a clotting cascade, and we could really scare you and show you what that looks like. It's a bunch of Roman numerals, but the anticoagulants, the warfarin, works on 4 of the clotting factors in your clotting cascade: 2, 7, 9, and 10. The direct oral anticoagulants, Xarelto, endoxiban, and apixaban, work on factor 10A. It inhibits factor 10A. And dabigatran works on thrombin. So it either works on one of the clotting factors or directly on thrombin, and it inhibits the thrombin formation. And it at the right dose, it doesn't totally stop it. It just slows it down so that you don't develop clots that become a problem. Is that
Okay,
simple enough, you think?
that's simple. Does a blood thinner actually thin your blood to where
No,
it?
it does not. It does
Okay.
not thin your blood, and it should not make you cold.
Thank you. Thank you for that added, because we do get that a lot.
Does not cause it. People will tell me all the time I'm on a blood thinner, and we use that term loosely. It really is not a blood thinner, like you said. It's an anticoagulant, and what it does is it slows the body's ability to make blood clots. It
Okay,
doesn't dissolve the blood
yeah,
clots. Other people think they take it
right.
so that it dissolves the clots. It does nothing to dissolve the clot. You have proteins within your body that dissolves the clot. Protein C and protein S are the most common, and I describe them as like little Miss Pac-Mans that go around and chew up clot all the time.
Yeah,
We're always making clot. I mean, as everybody's sitting here right now, we're making clots, but
that's right.
we have Pac-Man C and S going around making clots. That's why if anybody's on with a protein C or protein S deficiency, they will form clots more likely because they can't dissolve them as well because they don't have those proteins that go through and chew the clot up.
And and I know that can freak people out, right? It's like I don't think people realize we have all these little micro clots, our bodies producing them for a certain reason. And the body's a beautiful thing because they're getting broke down and it's happening naturally. But this is just something that happens to us. And I think having a better appreciation for our body and how all that works is really important. I just want to touch because you brought it up. And because we get this in the groups so often and we hardly ever touch on it, if the anticoagulant's not making them cold, why are people saying I feel colder now that I'm on an anticoagulant? Do we have any info on
I
that?
don't know, or it's just been such a myth for so long that people have just adopted that they feel colder, or maybe they are just colder. I mean, I don't, there's not a good physiologic reason for them
Okay.
to have a change in their body temperature. If you check your temperature, it's not any different.
Right, right. So how do clinicians decide which one they're going to prescribe for you?
So we're talking mainly DVT here, but there are certain indications where warfarin is the only drug of choice. That would be mechanical heart valves typically, or someone with a DVT that maybe has a strong positive lupus antiphospholipid antibody syndrome diagnosis. Warfarin is the better drug for that. The DOACs do not work as well. So if you have a good doctor, they will know that if you have a positive antiphospholipid antibody, especially if you're triple positive, you should not be on a DOAC. You should be on warfarin with an INR measured. And sometimes you have to even do special measurements of the INR with a chromogenic 10 level because of the way the the disease works. That's an acquired thrombophilia. For others, with the DOACs, it has to do with your renal function. If your renal function is impaired, your doctor may pick one over the other. Dabigatran is not usually used in patients with renal failure of any type because it's renally cleared. So it really goes by your renal function. Both Xarelto and apixaban can be used in patients with impaired renal function. And with the DVT, it's important to know, or with the PE, that there's not a reduced dose in the groups for the clotting patients, only with the atrial fibs. So you should be on a full dose with the DOACs for clot. Either you take the full dose or you go on warfarin if your kidneys are not good and your doctor doesn't want to take that risk. I think we have enough real world evidence to support the use of the DOACs. I use it some in the patient population now in renal. I didn't until I had enough evidence though.
Okay. Why is it so important that we remain adherent with these medications? I mean, we should with all medications, but my goodness, it seems really important with an anticoagulant, right? Why do people need to be consistent, not miss doses, make sure they take it properly?
So, well, warfarin, you have a little bit more wiggle room with warfarin because the half-life is much longer. So you can miss a dose. I'm not encouraging that. And it's not going to be as impactful as one of the newer drugs. The newer drugs have very short half-lives. So they're absorbed quickly, they're therapeutic quickly, and they get off quickly. So if you miss a dose, I've had patients clot that have missed 2 doses of Xarelto or apixaban. I've had patients clot when they've taken their apixaban once a day to try and to stretch their dosages out. It's a twice a day drug. You have to take it as prescribed. And that's what I tell prescribers and I tell patients. You know, if you're going to use this drug, do what's prescribed and take it as prescribed. If you don't, then you take the risk of having another event. And for someone, if they've had a big event, could it kill you?
Right. And I'm one of those guys being factor V Leiden homozygous, where if I'm off my anticoagulant for 36 hours, that's a guaranteed blood clot for me.
Yeah.
And we've been down that road before.
So
So
let me just explain, because you bring up a good point. So patients that are factor V Leiden heterozygous are much less of a risk. Homozygous means that Todd got a gene from both his mother and his father for factor V Leiden. So he's much more likely to clot than someone that's heterozygous.
yep, exactly. And there's a lot of folks with factor V Leiden out there, right?
Right.
Isn't it the most common?
5% of the Caucasian population is factor V Leiden positive, but 5% of them don't clot.
Yep. Okay. Last one for this segment. What are the risks of being on a blood thinner, and can someone stay on them long term, like for life?
Right. So the bleeding is the biggest risk with anything, and you should have a bleeding risk assessment at least every 6 to 12 months with your provider to see if that risk has changed. So your renal function may have changed. You may be falling a lot more. You may not be able to afford it, so you're rationing it out, and so someone needs to look at that risk. And it can be taken indefinitely. And I think we've had great evidence in the last 15 years since the DOACs came out, even going on to the maintenance dose of the lower dose for either apixaban or Xarelto have the approved lower dosage to go down to 10 or 2.5 on the DOACs to mitigate some of that bleeding risk. So yes, they can stay on long term.
And bruising, that's another. I mean,
Very
we
common.
bruise, right?
You are going to bruise because you have your blood is going to take longer to clot, so you are going to bruise. And if God forbid you're on an antiplatelet too, if you have heart disease and you're on aspirin, you're going to bleed even more because your platelets are not as sticky, so you're gonna bleed a little bit more with that.
Sure. Good info. Thanks, Diane. Leslie?
Just a follow-up, because I want to make sure that we're all speaking the same language here. So on the DOAC side, there's 2 dominant DOACs, one being rivaroxaban, which is Xarelto. So I live in the world of Xarelto, not rivaroxaban, which is the language that I use. And then Todd's on Eliquis, so he's apixaban. So
Correct.
apixaban is Eliquis, rivaroxaban is Xarelto, just so everybody understands that. Why is one taken once a day, i.e. the Xarelto, and the other one is twice a day, the Eliquis?
It has to do with their half-lives. So the half-life is longer, and when they design the studies, they do all sorts of lab monitoring in that to check the levels and the anti-10A levels. You have to have a special reagent to do that. And it was deemed safe and efficacious to do Xarelto once a day. And on the apixaban, it was a twice a day. There's pluses and minuses. So the plus to Xarelto is it's once a day. The minus is it has to be taken with food at the 15 or the 20 milligram dose.
And
Yeah.
that's for absorption
It is,
purposes?
yeah. So if it's, I thought I turned that off. Let me. If you're on apixaban or on Xarelto and you take it on an empty stomach, the efficacy is less by about 12 to 14%. So
That's
it's 99% efficacious if you take it with a decent size amount of food.
Yep.
That's a lot. I'm on Xarelto because I was incapable of doing twice a day, and I admit it. So it was easier for me just to do the one pill once a day.
Well, yeah, and I finally got used to it. I was on Xarelto for 14 years, and then when it failed, I switched over to Eliquis, and I thought it was going to be a problem. Turned out
It's not for you.
Nah,
Yeah.
not really.
Yeah. Okay. All right, let's move on. Next questions that have kind of come in that people want to discuss is what doctors are monitoring in your blood. So you've had you're diagnosed with a blood clot. How do they actually figure all of this out? D-dimer, are they doing ultrasounds? Like what's being used to get the answers that they need? And then once you've been diagnosed, they take a lot of blood from you. I've never had so much blood taken from me in my life, and nobody tells you what they're doing with it. So what are they looking for with all of these different blood tests? And, is it kidney function? Is it platelet count? Is it genetic mutation? Like, what are they looking for?
So let's start at the beginning of the clot. The first thing that they're going to draw probably at the beginning is a D-dimer. And remember Miss Pac-Man, C and S? Well, when you develop a clot, they go into overdrive and they chew up the clot. And a D-dimer is the amount of byproduct of clot that you have circulating in your blood.
Okay.
So normal is, I think, less than 75 at my hospital. We'll see people with D-dimers 13, 14, 15,000 with big clot. So that means that they have a massive clot and their proteins that are designed to dissolve are chewing them up, and we can measure that. So they'll draw that typically if you come in short of breath, without a lot of oxygen in your blood, having chest pain or a big swollen leg, they will go ahead and draw the D-dimer along with all the other labs that they would draw. They'll probably draw a baseline protein and INR just to see where that is, because that will help guide if you have antiphospholipid antibody syndrome. Oftentimes your protein will be elevated at baseline without any anticoagulation. Then they'll draw your chemistry to see if your kidney function is normal, because that will help them determine what drugs they can use. Do they have to use unfractionated heparin? Or can they use low molecular weight heparin if they want to wait and see? So not everybody may go on an oral medicine right away if they think they may have to take them for an intervention to take some of that clot out or to drip some clot buster in. They'll look at your CBC to make sure that your blood count, that's going to measure how many red blood cells, and your hemoglobin and your white count, as well as your platelets. Because if your platelets are really low, then they have to think twice about what are we going to do with this patient if they do have a bleed, because you need platelets to form those clumpy blood clots that we talked about. So those are the major things that we look at. The testing that you'll usually experience will be the ultrasound of the lower extremities. Oftentimes they only do them above the knee. When I order them, always order complete leg, because if it's right below the knee and it's growing, it's going to be in the proximal vessels very soon. So when I order an ultrasound, I would always ask for a full leg ultrasound. And then the other thing they may do is a CAT scan to check for pulmonary embolism. Or if your renal function is bad, they may do a VQ scan, which is you inhale some gas and they look for a mismatch in the lungs, and then they can determine if there's sections of the lung vascular bed that's not getting your blood supply. So those are the major diagnostic things. And then just depending on what your kidney function is, they'll determine that. And then for patients whose platelets are really low and they're on it, if this is an ongoing patient, maybe not during the acute phase, periodically we do draw those labs, and we have to watch their platelets. And when it's really a problem for any of the patients, and I'd say most of the cancer patients are now on DOACs, they're not on warfarin any longer, but a lot of the chemo drugs will really kill your platelets. And then at what point is it safe to stay on the anticoagulant with the life-saving chemo drug if you're going to bleed to death? So oftentimes when they got below 50,000, we would have that conversation with the oncologist and decide, do we keep this patient on anticoagulation now, or do we hold their chemo? And that's just a shared decision making between the medical team and the patient.
Yeah, okay. And then somebody mentioned whether or not people get an EKG also. I'm assuming that when they come
They
into
do, because oftentimes with the pulmonary embolism, you will have EKG changes. And you can have, with a pulmonary embolism, it can affect your heart. So you
Yeah.
can get a lot of problems with the right ventricle, because if you know anything about the circulation, the blood comes in to the right side of the heart, and when it's pumped, it goes into the lungs to get oxygen. Well, if the lungs get blocked, if you have a saddle pulmonary embolism, or you block one of the main bronchus vessels, then the blood backs up into the right ventricle, and it enlarges, and you can actually have the right ventricle fail. Those are hard patients to take care of, and that damage can be permanent. You can develop what's called pulmonary hypertension, which is high blood pressure in the vessels in the lungs because of the clot. And so those are patients that are very difficult to take care of and need a very astute professional to manage them.
Okay. That is a great response. Another question for you, just as a follow-on to that. So the patient has all this blood work done. They're, checking for different things in the blood. If they're on an anticoagulant and certain tests weren't done, so say protein C and protein S, because not everybody, as Diane, were checking everything. Can they have those tests done after the fact, or the results negated because they're on an anticoagulant?
That my school of thought and what I was taught was you don't test for thrombophilias during the acute phase of a clot.
Okay.
Oftentimes they're cured. And the medications, especially the heparins and low molecular weight heparin, not so much, but the heparins can affect them, as well as protein C and protein S, because during an acute phase, they're busy at work. So you can't do it. And for antiphospholipid antibody syndrome, you have to have testing 6 weeks apart. So you have to have 2 positive 6 weeks apart. So we don't routinely screen patients for thrombophilias when they come into the hospital anymore. It's really come full circle from when I started, 25 years ago in anticoagulation. But there is a place and a time for it. So if I have someone that comes in that's had recurrent fetal loss, we'll go ahead and test to see if this is because of a thrombophilia.
Mm-hmm.
We don't encourage, if you're positive, having patients, family members tested, unless it's like a factor, an antithrombin deficiency or something like that would really affect them. But what we do educate them on is, if you have a daughter and you've had a blood clot and you're factor V Leiden or a prothrombin gene mutation, go ahead and tell them not to take oral contraceptives.
Yeah.
That would not be in their best interest. So just, coaching them along, but it can affect their insurability if they come back as a positive, even if they haven't had a clot.
Yes,
So we have to be careful with that.
Yeah, no, that's a good point. We get that a lot from the patients also. I think we need to have 2 hours tonight, not 1 hour, because we have so much to cover. Todd, you're up.
Yeah, just want to touch on reoccurrence. I know we touched on it just a little bit. I've had 7 blood clots. I'm almost used to it at this point, but we kind of know why. But I'm going to ask you a 2-part question. So first, that's a really big concern with people, especially when they're newly diagnosed, because they think they're just going to keep firing off blood clots. Why is the risk higher in the first 30 days after you've been diagnosed with a blood clot? And what's the long-term risk of a second blood clot?
So during the first 30 days is when we worry most about the clot expanding and a piece of it breaking loose is what we're worried about. So the clot stabilizes during that first 30 days. You're taking the anticoagulation to prevent the clot from getting any bigger. We give you extra during the first. We do a loading period with either the apixaban or the Xarelto, or we cover you with, we bridge you with a low molecular weight heparin or heparin until your INR is therapeutic, because it's that important to keep, what we say, we kind of keep you wet during that first month so that the clot doesn't get any bigger and break off. After about 30 days, if tissue's going to form around that clot, because your body's not always going to dissolve the whole clot, you're going to have endothelial, is what the tissue is inside the vessel, will grow over it and stabilize it. And that's what we want, is to stabilize it or get rid of it. And so during that first 30 days, that's when the risk is the highest. It's also the same time where the risk is the highest for bleeding, is when we see patients that are going to be bleeders. Oftentimes they present during the first 30 days because they've never been on an anticoagulant. And if they have any kind of ulcers that are in their stomach or in their bladder, I've had 3 men diagnosed with bladder cancer because they had hematuria. These drugs do not make you bleed. They make you bleed faster. So there's got to be a broken blood vessel that the blood comes out of. So they're not going to erode your blood vessels. They're going to just present you with bleeding if you have any type of erosion in your blood vessels.
Sure.
And then what was the second part of that one?
Well, what's the long-term risk of a second clot?
So during the first 5 years, the risk is 20 to 25% for someone that goes off of their anticoagulation. And if it's an unprovoked clot. It's a little bit lower for a provoked clot, which we used to think that hold on, my thing keeps going off. Let me shut this thing off. I don't know why an alarm's going off at 7:40 at night on my phone. I don't have an alarm set. Anyway, for those that have a provoked clot, the risk is about 3% per year. So that would be like 15% at 5 years. We used to say, oh, it's unprovoked or it's provoked, they're safe. But what the data has showed is that once you've had a clot, you've declared yourself that you may clot again.
Right. We have a slightly elevated risk. So that's an even more important time to manage your risk factors. And just because we're on an anticoagulant doesn't mean we can just go off and, smoke a pack of cigarettes and be obese and have all these risk factors. It's really good habit to develop, a system. And that's what I want to talk to you about. This is kind of my follow-up, was about risk factors. I wanted to see if you could just touch on risk factors like smoking, obesity, immobility, certain medical conditions, the family history again. Maybe you could break some of those down and tell us, why do those matter and how can people reduce that risk?
All right, I'm going to make sure this alarm doesn't go off because it's very distracting. How do I make it stop? I know what I'm going to do. I'm going to throw it over on the bed. So the risk factors that are modifiable: obesity, we can all try and lose weight. Being obese increases your risk factor by stasis of the blood, because it doesn't make its way back to the heart as easily. It increases the risk because it's an inflammatory state, and it is also because you're not exercising, you're not moving around as much. For smoking damages the blood vessels and makes the platelets sticky. It also reduces blood flow. Immobility, you've got the decreased blood flow and stasis, which is one of the part of Virchow's triad, which is the 3 things that, one of the 3 things that we need for clot. And then you didn't mention cancer. Cancer is a prothrombotic state, so we can't change that. And some of the drugs that are used to treat cancer is also thrombogenic. So you can see patients that are on meds to treat their cancer that actually causes clots. So some of those patients with multiple myeloma may actually be put on blood anticoagulants to prevent clot formation as a prophylaxis. So that was that part. You had one more part to that, didn't you?
Just how people can reduce their risk. But that when you were talking there, I just wanted to ask you, why does dehydration, and I read a stat somewhere that like 75% of Americans are chronically dehydrated. Yeah. That is really scary. Why is that a blood clot risk?
Your blood is more viscous. So 90% of your blood is water. The rest are cells. So if you're dehydrated, you have more blood cells and clotting factors bumping into each other and partnering up and marrying up and deciding that they're going to take hold. That's why I think that would be one of the explanations for people that take long flights. Nobody likes to drink a lot on the flight because they don't want to have to climb over the person next to them to get up and go to the bathroom. Too bad. Drink as much as you can while you're on a
That's right.
plane. But
Yep,
not
that's right.
alcohol, not alcohol. Alcohol dehydrates you. So drink as much as you can fluid and get up and move when you're on when you're on an airplane or a bus or whatever, or even car rides. You decrease what you're taking in orally because you're not in front of the sink or the refrigerator. And like I said, you don't want to climb over somebody or have to stop on the road to go to the bathroom. But you should stop every 2 hours if you're on a long car ride and get out and walk around.
Absolutely. Leslie, I'm going to turn it back to
For
you.
how
We got a lot
long?
of talk.
For how long do you get out and walk around? 2
At
minutes,
least
5 minutes?
at least 5 minutes, I would say. Just walk
Okay.
around, stretch your legs, get the blood flowing.
Somebody wanted to know if soda, if you can drink soda, or is that dehydrating?
No, you can. I mean, it's based on it's got water in it, so I've not heard of any increased risk of clot with drinking soda.
Okay, good, because I had 2 frescas today, so I want to make sure that I can increase my risk factor. This next question is a little bit tricky because, especially for people who are newly diagnosed, they want to know what recovery can feel like. It's different for everybody, so it's kind of a hard thing to answer, but let's give it a go here. So, what can you expect the first 0 to 30 days, separate from what Todd was asking you about in terms of risk factors? This is really, and your phone is ringing again on the. I hope somebody's not from the group calling you directly to get an answer to.
No idea. I have no idea. Anyway, the first month is the scariest. Everybody will attest to being very scared when they're in their first month. And it's a new diagnosis. It's very common to be anxious. Patients will say they have a hard time sleeping. They're afraid to go to sleep, that they're going to die, especially after a pulmonary embolism. It's getting used to a new medication regimen. If you're on warfarin, you may have had to change your diet. It's all the what ifs. What if it happens again? It's going for more lab testing if you're on warfarin. It's getting back in to see that provider, trying to get the appointment when nobody has appointments, and trying to absorb all the knowledge you can. And then people will scare the bejeebies out of you.
Yeah.
They'll scare you. And so during that first 30 days, it's a big adjustment, and it's normal to be anxious. And it's the only question that you don't ask is the stupid question. So if you have questions, you need to be asking them. The only one that you don't ask is the dumb one. If you have questions, you need to have someone. That's why I always encourage patients to get an anticoagulation provider. We use our anticoagulation clinic at our hospital for all of our DOACs as well as our warfarin patients. So there's specialists that deal with this every day. During the
0 to 30, they should still anticipate having symptoms basically from
yeah,
getting
sure,
the
they'll have swelling in their legs. They'll still have shortness of breath.
Okay.
Hopefully during the first 30 days, the pain is getting better, the shortness of breath is getting better. It at 30 to 60 days, if the pain and the swelling isn't getting any better, you need to be getting in and seeing someone to see, is there something else that has to be done? Do they need to go in and do something with the clot? Have you developed pulmonary hypertension? If you've had a pulmonary embolism, did your doctor order an echocardiogram to check your heart to make sure your heart wasn't damaged?
Mhm.
That's gold standard. So, and if it was abnormal, did they schedule a follow-up once you've been on anticoagulation to make sure it's getting better? And then by 90 days, you should be feeling pretty back to normal, being able to do your normal activities, unless you've developed pulmonary hypertension or post-thrombotic syndrome, which we're not going to get into, but that's something that's very real for people that have had blood clots in their legs to develop post-thrombotic syndrome, which is because of the damage to the valves. The blood just pools in your legs and you have chronic swelling and pain in that leg. But there's interventions that can be done for that. So that's why I say it's important to stay in contact with your doctor during those first 3 months.
Okay, so anticipate that you're still going to have carryover from the blood clotting event for the first month, and then hopefully those symptoms that you have will decrease over time, with the exception potentially of the emotional impact, because we know from the work that we've done that that's a biggie for everybody. We've all experienced it, and that can go for years and years.
Exactly.
Okay, Todd, you're up to bat.
I want to shift gears, Diane, into daily lifestyle and some of the
Okay.
decisions we make. I've got quite a few questions within this. I'm just going to ask you a couple at a time. Are there certain foods that people should avoid or be careful with? And this is about when you're on an anticoagulant. And why do some anticoagulants need to be taken with food? I know we touched on it already. I'd like you to just touch on it one more time.
Okay. So warfarin's the only one that you have to worry about with food. And the take-home message is to be consistent with the green vegetables in your diet. Vitamin K is one of the clotting factor, one of the vitamins that is necessary to build the clotting factors. So if you eat too much of it, you're going to make too many of the vitamin K dependent clotting factors. And if you don't eat enough of it, you may not get enough. So it can make your INR go up or down. So the take home is to be consistent. To be absorbed with Xarelto, that one needs to be taken with food. So
Okay.
that we said, if without taking it on an empty stomach, you're going to lose about 14% of the efficacy.
Okay, and I just want to be clear because I see a lot of people avoiding eating salads and greens when they're on warfarin, and it's
No,
like it's not about that, right? It's
no,
not about avoidance.
no, you don't have to eat the same amount every day, but about the same amount of vitamin K each week. So if you normally have 3 salads, eat around 3 salads every week. Or if you do, spinach or collard greens or kale or that, those are higher in vitamin K. You need to be careful and make sure your portions are about the same.
And that's not a problem on a DOAC. You can
No,
have as
not at
much as you
all.
want.
No.
Okay. Let's talk about medicines. Is there medicine you cannot take while you're on your anticoagulant? And what about NSAIDs? What about herbal supplements?
So with warfarin, there's over 400 medicines that interact. So always check with your anticoagulation provider if you're on warfarin. With the DOACs, warfarin, nonsteroidal should be avoided because they increase your risk of having a GI bleed. One of the things that nonsteroidals do when you ingest them is it knocks out the protective mechanism in your stomach called prostaglandins, which protects the stomach wall from acid. So when you take a nonsteroidal, you knock them out and you expose the wall to acid in the stomach, and it increases your risk for GI bleed. Not to say you can't have one every now and then, but be aware if you have any black stools after that, you may have had some bleeding. And non-steroidals are going to be your goodies powder, your ibuprofen, Aleve, naproxen, naproxen, and aspirin is a non-steroidal. So don't take an aspirin just to take one every day because you're over 50 or whatever. Aspirin should be reserved for those patients that have coronary artery disease that need to take it. And then typically we always put them on enteric coated, so it goes down into the intestine to be absorbed, not the stomach.
Okay. Everybody's so stressed out with this stuff and we feel a lot of pressure and boy, it sure would be nice to have a drink. So what about alcohol and mixing alcohol with these anticoagulants?
So you're going to get mixed responses from your providers. I will put my clinician hat on and I'm very realistic. I like to have a glass of wine every now and then. I like to celebrate sometimes. But the take home is you can't get drunk on these. You should not get drunk on these. I'm not saying they won't cause you not to get drunk. I'm saying you should limit it to 1 or 2 drinks max because the risk of you having a bleed if you fall down is pretty high. If you fall and hit your head, and if you're on warfarin, those patients die when they bleed into their brain. The good news with the direct orals is the intracranial hemorrhages. You don't see nearly as many of them, is nearly as many fatalities as what we did with warfarin. So,
And it can be patient specific, right? So talk to your doctor.
right. Talk to your doctor. With warfarin, though, alcohol can raise the INR in some patients and it can lower the INR in some. So it's just a matter of, again, being consistent with if you're on warfarin with it. If it's someone that wants to have 2 glasses of wine a week, I would say go ahead and have 2 glasses of wine a week. But I never encourage patients to drink, but I was very realistic and I want them to have some form of lifestyle that they don't have to change that they enjoyed.
Got to have some normalcy. That's going to help, right? So, okay, last question. We talked about walking. Walking to me is probably the best overall exercise that's out there. What else is safe? What other kind of physical activity can you recommend for someone?
Swimming is great. Um, you can do dancing, you can do dance. The things that, we worry about is people that, they like to skydive and play football or contact sports. Even tennis can be a little bit iffy. But if you're going to bike, well, younger people like to skateboard, you want to make sure you wear a helmet.
That's right.
So that's the big thing is you said you want to get back on your bike, but you wear a helmet all the time. So
Not only that, I wear ab gear,
yeah,
padding for my
yeah,
abdominal because I mountain bike in case I crash. So you
yeah,
just got to think things through.
right.
Great information, Diane. Leslie?
What about multivitamins or vitamins overall?
Be consistent. Be consistent. We did not talk about herbs when we talked about meds.
All
There are
right.
several herbs that can interact with your medications, not just warfarin, but with your DOAC. So you need to talk to your provider because some of them can be inducers and some of them can be inhibitors of the medication. So if it's an inducer, it's going to make you metabolize that medicine quicker. And if it's an inhibitor, you could have an accumulation of that medicine. So I don't have a whole list of all the different herbs, but if you check with your doctor or your pharmacist, they can tell you which herbs would affect your medication.
Okay. And then just coming back to the exercise again. So we talked about, cardio wise things that we can do. What about weightlifting?
I would think weightlifting is probably okay. I mean, you're not, don't drop it on your toe. You're going to get a big black and blue toe, but I don't see that as a contact sport.
Okay. But maybe wait a little bit from the time that you were diagnosed until you
Yeah.
start.
And I would say, if you're doing it on machines in a controlled environment, it's probably fine.
Well,
Yeah.
and I have my chronic clot is not going anywhere and it stretches from ankle to thigh. And my vascular surgeon doesn't want me doing a lot of deadlifting and squats. And that kind of makes sense to me.
Yeah.
But I do think it is a fairly safe environment in the gym. And it's building lean muscle is an important part of even keeping your weight under
Keep
control. So I think it's
circulation. Yeah.
important.
Keep the
Yeah.
circulation going
Yeah.
too.
Yeah, for sure. And for women that are in menopause, postmenopause, they say that weightlifting is really important for them as well. So weightlifting is a yes, but check with your doctor before you
Yeah,
start back
for
into the
sure.
program. Okay. Moving on. Can you get pregnant after you've had a blood clot? So we get this question a lot from people in the group. They want to start a family. Is pregnancy safe after a blood clot? What precautions or special care should someone take if they're considering pregnancy, they've had a previous clot? And then two more questions. How does being on or off anticoagulation affect pregnancy planning? And what's the role of a high-risk OBGYN? Like, do you bring them into the equation, or a
Absolutely.
hematologist or both if you have a history
So,
of clotting?
yeah. The first question is, can you get pregnant? Oh, yeah, you for sure can get pregnant, but the question should be, should you get pregnant after a clot? So I made the mistake of one time telling a warfarin patient that had come off birth control and was on warfarin that you can't get pregnant while you're taking this. So she thought it was a form of birth control.
Oh,
It is not. So yes, you can get pregnant, but this needs to be a shared decision making between you and your OB, and you want to plan it out. So the further out from your clot, probably the better. I would say not during the first 6 months after your clot, especially if you've had some, a lot of times we see women that were on birth control and then they come off and they're like, okay, well, I might as well just get pregnant now. You got to wait a little while, let your body dissolve that clot, and then just realize that pregnancy is a prothrombotic state. Your body is getting ready to deliver a basketball and you're going to have a lot of bleeding. So it upregulates towards the end. The medications, the DOACs, have not been studied in the pregnancy population. So it is not safe to take any of the DOACs during pregnancy. Warfarin can be taken from week 0 to 6, but week 6 through 12, it's tetragenic. And so the majority of women that have planned pregnancies after a blood clot will end up coming off their anticoagulation, going on either a once or twice a day injection of low molecular weight heparin. And they'll be on that for either the entire pregnancy up to 6 weeks are you postpartum, depending on if they're going to breastfeed. So it is a big decision. And the scariest time for a woman after birth is when the risk is highest for developing a clot.
Mm.
So most pregnancies that, like I said, are transition to low molecular weight heparin, you should talk to your anticoagulation provider before you get pregnant if you're planning, or as soon as you suspect you're pregnant or you have that positive stick in the bathroom. And then by all means, if you do get pregnant and you need to be anticoagulated, you should be followed by a high risk OB. And they should be present and make the delivery plan. Most of the deliveries are induced and either C-section or they're a planned induction, so they can control the amount of anticoagulation you have. They will oftentimes bring you in and take you off your unfractionated heparin, or your low molecular weight, put you on unfractionated heparin, stop the heparin, and either do the C-section and do the induction. And then as soon as they're done, you're back on anticoagulation.
Okay. Also IVF, you've had a clot, you can still use IVF, but same
That is not my specialty, but they use a lot of hormones with IVF. So I would say you would defer to the high risk OB and a hematologist then, because I don't know for sure what all hormones they're using these days with
Yeah.
IVF, because I haven't been in that arena.
We have our thrombambassador, one of our thrombambassadors is Katie Hoff, the Olympic swimmer, that works with us, and she is chronicling her IVF experience. She's a blood clot PE survivor, obviously unprovoked, ended her competitive swimming career, and she's going to be highlighting basically her IVF experience, which
Well,
will
that'll
be,
be interesting to see
yeah,
what they do. I would think they keep her anticoagulated the whole time. They're not going to take her off.
yes, exactly.
Yeah.
She is, or she will be. Okay. I think given the fact that we've got so many questions and we're running out of time, actually, that maybe we start moving into the question section of tonight's event, Todd.
Absolutely. And so this is kind of a two-parter, Diane, and I'm pulling this concern and this question straight out of our very large support group because it is a daily thing. I'm going to put myself in the role of this person asking the question. I'm walking down the stairs, I stumble, I take a hard fall, I do not hit my head. I bang my knee, I bang my thigh. Should I be concerned about a blood clot? Should I be concerned about bleeding? What should I do?
So, because you didn't hit your head, I don't think you have to go to the emergency room right away. I think what you need to do is monitor the areas that you banged and look for a bruise or a hematoma to form. I would not be worried about a clot. I would be more worried about a bleed. If you have a bruise, mark it with a pen and watch if it gets bigger or higher. If it continues to grow, then go to the emergency room.
Okay, so, and you kind of answered that other question that I had was, if you fall down the stairs or you slip on ice and you hit your head on the concrete or a slab of ice, you really should go get checked out at the emergency room, or
Right.
should you just monitor symptoms?
No. What would you think? How much blood can you accommodate around your brain before you start having compression? How much would you think?
Not much.
A teaspoon.
A teaspoon.
Wow.
Wow.
Right.
That puts it
That's
in.
why everybody
Okay.
should have been told, if you fall and hit your head while you're taking an anticoagulant, you go to the emergency room, you tell them on a blood thinner, and they will do a CT of your head.
Okay. What if I'm in the kitchen and I raise my head up, not super fast, but I bump it on the corner of a cupboard door?
A little bump I wouldn't worry about.
Okay.
If it's just, you just banged into it, it's okay.
I always say we should always know the symptoms of brain bleed and monitor, right?
Right. And always remember, if the bump comes out, that's better than the bump going in. You want the bleed to
good
come out,
too.
not in. So if you
That's
get,
right.
you get a goozle on your head and it comes out, that's a good thing. You don't want to bleed into the head. You want to bleed out of the head.
Got it. Leslie?
That makes good sense. Okay.
Does.
I was diagnosed with multiple bilateral PE on 21st of April and am still experiencing dyspnea accompanied by anxiety with activity. How long will this last? The anxiety obviously is different than your SpO2. How do you differentiate between dyspnea and anxiety? That's a great question.
Yeah. So are you having air hunger and that's making you anxious? So I would definitely check your oxygen saturation, get a little pulse ox. You can buy one of those for $10 on Amazon, and measure your heart rate and your oxygen level. And you want your oxygen level to be above 92% is what we consider normal. If you're 92, 93 and you're a young person, that's probably a little bit low. But if you're having trouble laying down, if you're better during the day and when you lay down at night, you're having more trouble breathing, that's a sign that that heart might be involved. So share that information with your provider, because your April 21st was the PE.
Yes.
So I would be calling my doctor and saying that the shortness of breath isn't getting any better. And they may need to do an echo. I don't know if this person had an echo to begin with, but just let them know. And just know that the anxiety is normal, but is the anxiety because you're not getting enough oxygen? Because that will make you have air hunger for sure.
Yeah.
Or anxiety for sure if you're having air hunger.
I totally understand what this person is going through, because I lived this after my blood clot diagnosis, and I'll make a pitch for cognitive behavioral therapy, because it really, really helped me
Yeah.
to kind of bifurcate what was physical and what was, mental for me, which lasted a lot longer than the physical stuff. Todd?
So whether you've had a DVT or a PE, from what I've experienced and what I'm seeing in other patients, is it makes you feel like you just got hit by a truck, and it sucks every bit of energy that you have, and you're fatigued for quite a long time. How long does fatigue actually last after a blood clot?
I don't have a good answer to that, Todd. I don't know. It can depend on other medications. If you were started on a beta blocker because your heart rate was high, or they discovered something else, you really have to look at each patient individually. And I don't think there's a good, and it's probably not something that we've really measured. It's not something I ever really, as a provider, I'm kind of ignorant of that. I never paid attention to patients saying that they're chronically fatigued with it.
Okay.
It
I'm
wasn't
sure
something that
it's
patients complained a lot about to me.
I'm sure it's going to be different for everybody.
Yeah.
Yeah.
Well,
Leslie?
this is why we always say everybody's unique. So make sure you speak to your clinician about your unique situation. Okay, if I had a blood clot, I had a PE after surgery 15 years ago with no further episodes, can I be claimed to be out of the woods and not have to worry about getting another blood clot?
No,
Thank you.
I don't think anybody is out of the woods. I think everybody is at risk for developing a clot. And once you've clotted, whether it's provoked or unprovoked, you've declared yourself as a clotter. So if you have to have another surgery, you're going to be at risk again for having another clot.
Yeah, and that's really important. So if you're going into the hospital, you've had a clot, no matter how long ago it was, make sure you tell your providers and ask for a risk assessment. We have that at NBCA. You can download it, take it with you. It's a really important thing to have. Check those boxes and just make sure you have that everybody knows you had a history of this, and ask for a risk assessment. Okay, Todd?
So somebody's asking about, and this is something that I've experienced, is how do you tell the difference between referred pain? For example, I had pain in my neck and in my jaw for pulmonary embolism, and then later on I found out that that's referred pain from the actual clot site. How do you, especially early on in diagnosis, is there a way to tell the difference between what's referred, kind of the natural recovery pain, and a brand new clot, and when they should go to ER? That's probably not a very easy answer either, is it?
No, typically what I'll ask patients is this pain similar to the pain that brought you to the hospital in the first place? Because the chance of you developing another clot in a different spot while you're on anticoagulation, you're not going to have pain in you're going to have pain in your chest if it's a pulmonary embolism. You're going to have pain in your leg if it's a DVT. The sophistication is such now that we can determine if it's old clot versus a new clot on ultrasound. There's different ways that they look at the images, and they can say, yeah, this is an old clot, or they compare it to where the other one was. So I would say if the pain is excruciating, then you need to go to the emergency room, and you need to let your body guide you. If the pain is consistent and hasn't changed, I don't think the clot's getting any bigger. but it may be just taking longer for your body to dissolve the clot. And remember, it may not totally dissolve it. You may be left with some permanent clot. And CTEPH is another thing that patients can look up, that they've had pulmonary embolisms that the endothelialize around, so they always have chronic thromboembolic pulmonary clots in their lungs and can develop that pulmonary hypertension from that. So just be aware, because you're on anticoagulation doesn't mean that the clot is going to go away. So, at some point, if things don't improve, they may have to re-image you to see if they're doing that, or if it's been a pulmonary embolism, they may have to do a right heart catheterization to see what the pressures are doing in your heart.
Mhm.
Just a follow-up to that. So somebody wants to know, is there a risk that the body gets used to being on an anticoagulant and becomes less effective?
No, not that I've seen. I've seen failed anticoagulants. I've seen patients that have failed on some, that, those typically are people that have an underlying malignancy. It's been my experience where we've had patients that we are 100% sure they took their anticoagulation just like they were. If they were on warfarin, they had their INRs checked regularly, but then they present with another clot. So then we look for an underlying malignancy, would be what we would do, make sure they're up to date on their cancer screening. Those are about the only ones. I've had people that have failed on the Xarelto or the apixaban, very, very few. But what we'll do is we'll switch them from one to the other. If they fail both, then we put them on low molecular weight heparin.
Okay.
Who diagnoses post-thrombotic syndrome? So a lot of people end up with quite a few issues after a severe DVT. Who actually diagnoses that, Diane?
Usually vascular surgeons will diagnose it, because
And does,
they'll do multiple serial images, and they have more sophisticated testing to do that. And I mean, it's chronic swelling in the legs, and it's very, very painful. The patients often will develop venous stasis and ulcers on their legs, and it really impacts their life.
yeah, it does. I've
Yeah.
seen that in the support. Does compression help with the swelling?
The sooner you can get compression on, the better, is always been my school of thought. And the compression is not comfortable in the beginning because your leg's already swollen. And as the swelling goes down, you have to get smaller stockings then, so that you keep at least 10 to 20. During that clot phase, the studies were done with 30 to 40. I don't think I ever had a patient tolerate 30 to 40 millimeters of compression. It's just really, really tight on your legs. So, whatever compression you can tolerate in the beginning. And if you can only tolerate the knee high, that's still going to pump the blood back to your heart. So some patients we can get to where the thigh highs or even the pantyhose, but for the most part, the knee highs. And now I think you can order them on Amazon. I don't even think you have to have a prescription for them any longer.
And I think some of the prescriptions, they're now covered by some insurance. I don't know how much of it, but some insurance. Actually, next month, July, we'll be addressing compression. We have an annual PEP with Dr. Rasan, who's on our medical and scientific advisory board also, and it's all about compression. So anything and everything that people want to know about compression. I'm going to do 2 more questions, and then I think we're going to call it a night because we've really run over with you. Can you use CBD with your anticoagulant, either Eliquis or rivaroxaban?
As far as I know, CBD, the oils.
Well, there's 2 kinds, I guess. Let's address them both.
So marijuana will lower your INR. I don't know of any effect of it on your DOACs.
Okay.
So I would not think CBD would affect the DOACs. Whether it does, because it's probably a plant-based derivative, it might affect your INR. I don't know.
Okay. Fair enough. Todd?
Could you ask another one? Because I was looking for the one I wanted to ask and I can't find it now. Do you have one ready to go?
Sure.
Oh, give me 5 more. I can do 5 more.
We have, I mean, I have to be honest. We've had so many questions come in. We've got pages and pages and pages of questions.
Yeah.
And it makes me so angry that people aren't getting the information that they need. This is just unbelievably frustrating that they're not getting the information they need when they're diagnosed.
Hey, Leslie, I found it. Can I just ask it real quick before I lose it again?
Absolutely, and I will stop ranting. So we're very thankful, Diane, to have you here tonight, but it really, it's distressing.
It is, it is. Diane, and this is one that it came through in our questions, but it's asked a lot in the group. They're on an anticoagulant, they've cut themselves, but they're not bleeding any more than what they would normally. Does that mean that the DOAC isn't working?
No.
Okay.
No.
They just got lucky.
They
I
did.
feel blessed because I don't
Yeah.
bleed a lot, so.
They didn't cut a big enough vessel.
Okay, so
They didn't make a
there's
big enough
still,
hole. Yeah.
even if you're not bruising a lot, even if you're not bleeding a lot, your DOACs, it's still working. Okay, Leslie.
Right. As long as you're
Okay.
taking it as prescribed.
Okay, so many questions. Does muscular dystrophy in wheelchair use mean a higher repeat incidence of blood clots?
I would think because of the mobility, probably yes.
Yeah.
The
And
immobility.
so for somebody who is in a wheelchair or has mobility issues like that, what should they do?
I mean, they're on an anticoagulant, and that's about all. I mean, they could have passive range of motion if they have a caregiver that could exercise their legs for them, just to try and keep the bloods flowing. But I mean, if it's causing too much pain, then you can't.
Okay. All right. Todd, you want to take the last question, and then we do want to
Yep.
see if we can get folks to answer one or two poll questions before they leave. So please don't leave yet. And Todd, I'll turn it back to you.
Yeah, I'm gonna pull this one out of the Q&A box here. How long could one have a pulmonary embolism without even realizing it? Is that possible? And could one have subtle symptoms months before even being diagnosed with a PE?
Absolutely. We constantly find them on incidental reads on CAT scans where a patient will come in and they'll have a CAT scan for something of their chest and they see the pulmonary embolism there, and then we have to call them back and they've totally been asymptomatic. So it could be there, and there's no way to know if that was a new one or an old one.
Yeah,
Okay.
okay. Let's make sure, I know Jen is behind the scenes working here, that everybody has access to the new patient guide, because that is a wealth of information. It's developed for patients by patients. It's been blessed by our medical and scientific advisory board. So please, by all means, get full access to that, everybody. And then Todd, let's pop up the last poll or two question, and then we'll call it a night.
Yeah, Jen's gonna pull those up for me so I can read them, and here we go, that fast. Did you find the discussion tonight helpful? Yes or no? And our second question, last question, has tonight's discussion helped improve your understanding of the role of your anticoagulant treatment? Yes, no, or not applicable? You just answer those real quick, and we're gonna fire off the answers and let everybody knows what those were, and we will tell you good night. But this was an amazing, Diane, thank you so much for
Yeah,
You're
thank you. This
so
was
welcome.
incredible.
so many questions. Okay, did you find the discussion tonight helpful? 99% said yes. And has tonight's discussion helped improve your understanding of the role of your anticoagulant treatment? 96% said yes. And I think those are good numbers, Leslie.
Yes, I don't know who this 1% person is, but
We're not paying no attention.
I think 99 speaks for itself. Diane,
Yes.
thank you. July is compression. We hope to see everybody for that. Diane will be back in September. So if you're newly diagnosed within like the last 20 years and you want to show up and ask your questions, please do invite your caregivers as well to participate in that. And thank you, everybody, and have a great night.
Thanks, Leslie. Thanks, Diane. Good night.
Bye, guys.
Thanks. Bye-bye.